in the Division of Infectious Diseases at the University of California, Irvine School of Medicine. And her research focuses on hospital-associated pathogens and infections, especially antibiotic-resistant pathogens. And she has led several large randomized controlled trials involving decolonization that have changed current practice in hospitals today. All right, excited for the talk. Thanks.
Thank you. It's a great pleasure to be here. I got my MPH here, so I was walking around some of the hallways and remembering certain classrooms. So it's been really, really terrific. And thank you for the invitation. So I'm going to, I came up with this title a while ago, and I think I meant it to not pigeonhole me when I wrote it. And then when I looked at it, when I was preparing this talk, I thought, wow, I can talk about a million things. So I thought I might do a little bit of a survey of a few things and kind of not go too deep, but tell you a little bit about some of the controversies, some of the recent findings, and that might spur enough for questions that might come up later. I am doing clinical studies in nursing homes and hospitals that receive contributed antiseptic products. We all know that there are a lot of multi-drug resistant organisms, or MDROs, and unfortunately the ones that have been around for a long time don't go away, and there are new ones that come up every several years. And so part of our complexity of medicine is to try to figure out how to address things that are already here and things that are up and coming. CDC a couple of years ago put some numbers down to these, and just to show that there are, it's not a small problem. These cases are infections, and so when you look at this, there are major numbers. Still MRSA at the top of that list at 323,000 cases, about 11,000 deaths, and shortly behind the ESBLs, these are gut bacteria that are highly resistant, and you can see that they also cause a very large number of cases and deaths. And there are burgeoning things like Candida auris, which is an emerging fungus that is causing a lot of trouble around the world, and including in Orange County, California, where I'm at. We also know that the problem of antibiotic resistance got much worse with COVID. Pretty remarkable considering it's a virus that you don't need to treat with antibiotics. And unfortunately, especially here in the United States, it's really, really hard for clinicians to see someone not do well or potentially dying and not throw every antibiotic known to man at those individuals. And so we did a real disservice to antibiotic resistance across that period. And you can see that every single MDRO that we had made pretty sizable headway with actually did a U-turn, and we ended up in a far, far worse place across the country because of it. So I thought that I would talk a little bit as we think about all of these MDROs and what can be done. I won't focus on, how do resistance genes emerge. I'm going to talk a little bit about what we can do on the other side. We know that these things transmit, and maybe there's a way to consider the multitude of things that we can put into place to try to stem the tide. So humans, we are a plume of bacteria that kind of sheds in a cloud around us. And we, as we do that, these pathogens can get into the environment around us, and they can stay there very, very happily for days, weeks, many times months. And unless we clean them, which we're not particularly good at doing, we can pick them up from these surfaces. And as providers, healthcare providers, we can bring them from patient to patient if we don't clean our hands, if we don't wear kind of gown and gloves and other types of barrier precautions when we're supposed to, and we can bring them to the next patient. And that patient, we know that the highest risk factor for having an infection with a multi-drug resistant organism is being colonized with an MDRO. And so if we put it onto that person, then they incur a risk for infection. And there are lots of things that we can either do or hope we can do in the future that can try to stem these types of things from happening in this cascade. And I'm going to talk about just some of them and where we are in the field today. So these are kind of what we consider to be some of them basic strategies. I'm not going to talk, for example, about hand hygiene because the answer is yes, you should do that. I'm not going to talk about vaccines because we don't have them for these MDROs, but I'm going to talk a little bit about each of the things in between and try to give you just a little bit of the lay of the land. So this is one of the basics in infection prevention. If you go into hospitals and we're trying to stop a organism, and that's wearing gowns and gloves for patient care and putting them into a single room. But the contact precaution world, the world around contact precautions has been starkly and deeply divided for a really, really long time. So this is a multi-decade controversy where people in the field are very much on one camp or the other. There is really no controversy that healthcare providers can get contaminated. There's no discussion about that. There are many, many hundreds and hundreds, probably thousands now, of papers that demonstrate that if you go in and you care for someone, absolutely, they can transfer their organisms to you. And you can swab hands or gloves or gowns, and you can demonstrate that not only does it transfer at a fairly frequent rate, it depends on the organism, but you can then actually look at the genomics and prove that it's actually that person's strain that came on to your body. Where there is intense disagreement is on how much it matters that the healthcare provider has picked this up and whether or not it actually does any harm. And so that would require us to measure infections. And that's really, really difficult for the field. Most people in infection prevention are representing a hospital. And so they're only looking at the vantage point, this time horizon of the stay. Those stays are generally 3 to 5 days. It's not very easy to tell someone that it matters when they're seeing all these people kind of come in and out of our hospital and we're not giving them infections every single day. So our limits on providing the right kind of evidence is that we have measurements that are of insufficient duration and insufficient scope. A lot of hospitals will look at their one hospital for a short period of time and declare that it does no harm. The ability to look much more broadly requires big systems, a lot of data, and maybe even swabbing people over time to show that they've picked it up and then get into trouble later. So we have lots of problems with that. And probably on top of all of that, there is this very intense staff fatigue. And it's a really interesting phenomenon in public health that if the problem gets too big, you back away from it. And that's very typical. I'll give you an example of when measles came to the Disneyland area. And when there were only a few cases, we would go at it, we would draw titers, we would do all sorts of things to try to search and destroy. The minute the numbers went into the hundreds, into the thousands of contact tracing, public health backs up. And you just start to do Band-Aid measures of things. There's no more drawing of blood. You're either just going to vaccinate or you're not. And so it's that same kind of sentiment about contact precautions. As the pathogens become more prevalent, the tolerance of doing something about them goes down. And it's in that, that kind of dynamic of culture and mental fatigue that we have to think about these recommendations about what we can do to stop the spread of MDROs. For example, if you look across the United States today, most of the fatigue is around MRSA. That's been around the longest, but I just showed you that it's the highest number of disease and death. But that's where the fatigue is the highest. When things are new, like Candida auris or like carbapenem-resistant Enterobacterialis, where something is infrequent, then they will tolerate doing something for that. And so there are lots of things that we have to consider based upon fatigue. This study came out this past year, and it was large in scope. I told you what the problems are for evidence. This was large, 123 hospitals, and the VA system has been well known for the past couple of decades as being at the very forefront of using contact precautions and demonstrating the value of doing that. So they actually said that every single hospital across the United States was going to have an MRSA coordinator. They actually paid for that person to exist. That person actually not only insisted that every single person who comes into the hospital was screened for MRSA, but they had to ensure that they were actually placed on contact precautions and that it was actually done in a high fidelity way. So something that most systems don't have. One person whose entire job was to control the spread of this one pathogen. And they were able to demonstrate year on year and every 5 years, really stellar data in being able to bring their MRSA healthcare-associated infection rates down lower and lower than any other group across the United States. And all they were doing were screening and isolating. And so they came up against the COVID pandemic in a very different place. They had these measures in place for MRSA. And then, like all of us in healthcare, when the pandemic hit, we had problems. We had problems because now we had to divert laboratory personnel to intense amounts of COVID testing. And we had to divert our gowns and gloves and other types of things to take care of every person who came in with a respiratory symptom. And because of that, there were immense shortages of personnel and PPE. And therefore, the VA put out an unprecedented statement, and they said, do whatever you want. Like, we can't handle this shortage. You're going to have to make local decisions. And the only thing that we ask is that you report to us every month exactly what your policies are saying. So they collected all this information, and the outcome was still MRSA hospital-associated infection rates. And so this is a really busy slide, and I'm only going to just show you the variation that existed. So you don't have to remember anything, but here we go. Remember I said every hospital had this MRSA coordinator, so all of them were doing screening, all of them were doing isolation, whether you're infected or colonized, at 100%. When the pandemic hit, this is how many people, how many of the hospitals were left doing all of those things. And you can see that at the lowest point, it was 20% of their hospitals, 80% of their hospitals doing some fraction of that all the way up until none. And you can see even at the end of their measurement period, they got back up to maybe 60%, but not back to 100. You can take a look at those that did nothing or almost nothing. It was about 15%, and then it waned over time as they got out of the pandemic and they were able to put things back. They would try to put some pieces of it back together, but there were a fraction of folks that were doing really nothing, or they were screening and not telling the providers to do anything. So the providers could do something if they felt like it, but there was no policy that insisted that they go back into contact precautions. And then there were folks who stopped screening, but still put whoever they happened to know about into contact precautions. And then there are others that did kind of some variation where they would screen, but only put you into contact precautions if you were infected, but not if you were colonized. So every combination in these 123 hospitals. And so then what they did is they took these data and the months that people spent doing these various things. And then because they are a large system with a large number of patients, they could estimate the MRSA HAI rate, the healthcare associated infection rate. And you can see that as you lose things, your rate goes up. So this is probably the largest demonstration. Not only did they demonstrate that if you put it in place, you can reduce MRSA in their hospitals, but now they're showing that if you remove it, you'll actually cause harm. And so you can see when you do the green is do everything. The left-hand side is the ICUs. The right-hand side is the non-ICUs, and that's the difference in the infection rate. And you can see when you let it all go, you can see a big, big loss, about a threefold increase in MRSA healthcare-associated infections and almost a twofold increase in the non-ICUs. And so what would you think that the VA would do, right? They're the ones who promulgated this great strategy. They're the ones that now demonstrated that it worked, and they can quantify the loss for actually having taken it away. So what's really remarkable is they couldn't put it back. So they decided that that there was such discontent among the different staff members for having this contact precautions in place that they were going to allow variation. And not only that, they had given enough hospitals this taste of freedom. And there's all these people on the ground that are looking around saying, well, I didn't see that half my patients died. And so why do I have to bother to put on this stuff when I'm going in and out of these rooms 100 times a day? And this is going to slow me down. So it's just a reminder that evidence in the setting of context and social norms and social opinions can cause a deep divide in both the regulatory community, certainly in the guidance communities, and even at the frontline staff. We had to account for this even in the one of the guidance documents that just came out from the Society for Healthcare Epidemiology of America. I'm trying to give an example that it's fine if you feel so strongly that you want to stop doing this, then you should at least understand the magnitude of delta that intervention provided, and you need to find a replacement. You can't just walk away and say, we're going to stop because I'm tired. You have to then think about something else that you can do that might have the same or greater effect. to protect patients from these pathogens. So what might that be? So I'm going to talk just a little bit about environmental cleaning, about where we are with this. This is just old. A lot of these data are really, really old, and there's a lot of it. I'm only showing just the tip of the iceberg, but to show you that it doesn't matter if you're infected or colonized. So I just said that some hospitals and a lot of nursing homes, they say, okay, it's fine. If you're infected, we'll put you in gowns and gloves, precautions, but not if you're just colonized. Well, we know that the plume around you doesn't matter whether you're infected or colonized. You still shed pretty profusely into the room around you. That is definitely true for the gram-positive pathogens, a little bit less true for the gram-negatives, but it still, of course, occurs. This article just showed how long things are heavily sitting on dry inanimate surfaces, tables, desks, chairs, and you can see that it's really quite hardy. In contrast to most viruses, bacteria are very, very happily living in our environment around us. And these are some of the data showing that we don't clean well. And this is not surprising probably to any of you, but our ability to clean with high fidelity when we're talking about a worker staff that is fairly low paid, we really don't tend to do a really great job, and we don't really have a way of controlling and making sure that they do a great job. And so if we take a look, these are a lot of the data that show whether or not it matters the room you go into, what the person had right before you, right? So you're about to get hospitalized, you're going into an ICU room, and you just happen by luck of the draw, you're going into a room where the person right before you had ESBL or had C. difficile or had MRSA. Does that impact your risk of actually acquiring these pathogens and then ultimately developing disease? And so there have been a series of studies that have looked at this, and generally the answer is yes, it does. It actually impacts you, and sometimes it even impacts if that person had antibiotics during the time that they were in that room. So these types of things are really important to understand, because the assumption, of course, is that the room wasn't clean. So these rooms aren't sterile, but they really are supposed to be cleaned well enough that we don't transmit things that can produce significant disease. So the types of work that people do is they put these invisible markers, these UV markers down. And one of the bigger applications of this came a couple of decades ago, where they used to use these kind of glow lights, but they were really meant to have you fail. They were really hard to get rid of. And so you could put it on and it will never come off. And so then it just looks like nobody's cleaning particularly well. And so one of the changes was that there was the development of a UV marker that was fair. And it really did come off quite easily when the cloth was moist. And if it was damp, it took a little more elbow grease to actually remove it. And it was quite fair. And all of a sudden now you actually have something that can be useful, that even the environmental services workers would trust. And so there are all these marks that you can put around different pieces of equipment, high-touch surfaces that should be ultimately cleaned. And they showed that in addition to visual inspection, which is what everybody does, is they check and make sure that the room looks clean, that you can use these markers and you can actually get the cleanliness in a hospital, which usually rides around 40% of marks will be removed. And you can get it up to about 85% with hiding these dots and doing active feedback. And you can keep it going kind of for quite some time. And so, this was one of the major movements for environmental cleaning, to be able to give kind of feedback of a difficult environmental task. There were limitations, of course. These UV markers can be really expensive. They're probably incredibly cheap to make. It's kind of like cereal. It's really cheap, but then they get the markup at the front line is astronomical, right? So these markers, the way that they decided that they would try to make some money on it is you can't buy it just the substance. You have to buy the program. And so because it has a program and it has a software component and other stuff, it becomes quite expensive. And then it takes persistence, which is really, really hard to do. I'll just showcase this because we were really interested in saying, well, okay, we know that cleaning in the United States is once a day. Cleaning of a hospital room, a nursing home room is once a day. And we thought, well, okay, if we're really, really, really worried about something like Candida auris, maybe we could just show that we just need to clean twice a day. Like, what's the speed at which recidivism occurs? You know, this person's a plume, but does it really kind of contaminate the environment really, really quickly? And you can see the bounce back is incredibly fast. You know, and you can see again, as I mentioned, it's worse for the gram positives than it is for the gram negatives. These are all high touch surfaces around a patient, both in nursing homes and in hospitals. And you can see that Candida auris, which is known as the fungal MRSA, acts very, very similar to MRSA. And so this limits our ability to think about cleaning as the solution to everything, because it just doesn't work often enough, fast enough, and robustly enough for it to solve all of our problems. So we've been really interested now for a long time on this concept of decolonization. So, you know, what on earth is it? It's kind of this complex term, but it's this idea that if we are the source of a lot of these bacteria that kind of shed into the space around us, can we use topical agents, so topical antiseptic soaps and nasal ointments, and can we just reduce what's coming off of the body during the times that it really, really matters? So not in perfectly healthy folks that are just living their lives in the environment, but these moments that matter. And when is it true that our own bacteria actually become our own worst enemy? So these are moments when we get a surgical incision. They're moments when we have pressure ulcers, or our skin is raw and it's got a rash and it's denuded and I have abrasions. So all these times that we can't shower and we can't bathe because we're now in a nursing home or we're sitting in an ICU bed. All these moments and we have devices coming out of our arms, all these moments provide an opportunity for high vulnerability and for us to actually do something to keep that risk profile down. So I had showed you this before, and one of the reasons why we were so intrigued with decolonization is that it works at this outset of this cascade, right? So at the top, if you can stop this plume that happens from people, then actually it's been shown in a series of varieties of papers that you can actually stop everything downstream of that plume. The environment is actually cleaner. The healthcare workers' hands that give the bath are actually cleaner. And ultimately, you can stop acquisition and you can stop infection. And the other reason why we've been so interested in decolonization is that everything else that I've shown you about these basics of infection prevention, this idea of cleaning your hands, of cleaning the environment, of wearing gowns and gloves, its intent is to stop it from going from someone who already has an MDRO to someone who doesn't. It does nothing for the person who already has it. Decolonization is the only infection prevention activity that does something for the person who has it. And when you look at a hospital and there are 10 or 15% of people who have it, you don't really want to say, well, too bad for you, I'm just going to care about these other 85 that are kind of free of the germs that you have. If you look at a nursing home where 65% have an MDRO, you're basically saying that for the majority of the people in that place, you can't do anything for them. And if you go to an LTAC or a long-term acute care hospital, these are chronically ventilated people on breathing machines, it is 80% in those facilities. So it's really important that we think about the way in which we can not only stop transmission between us, but actually do something for someone who already has it on their body and prevent them from having the bacteria dive in an inopportune time into a wound that they happen to have. So we've looked at a number of things, but the most studied products are actually old. If you look at the things that we've been studying, they've been around in healthcare for over 60 years. This is chlorhexidine, chlorhexidine gluconate, or we call it CHG, povidone iodine, which you can go into any pharmacy. Actually, you can go into any pharmacy and get all of these things except for mupirocin, and just over the counter, I mean. And so these things have been around for a really, really long time. And so I thought I would just tell you some of the story. It's been a long time. It was first used, it was discovered by a company that was looking for an anti-malarial. And instead they found an antiseptic and it started to use it for hand antisepsis. It's been used by periodontists for decades and decades to try to help with gingivitis and other types of diseases. And then the trials came, and there were a number of trials that were looking at what's the best thing to clean the skin before you actually have to put a device into the skin, a central line. And those were definitive trials that demonstrated that, surprisingly for everybody, it wasn't alcohol and it wasn't povidone iodine, it was actually chlorhexidine. And then the trials came looking in the surgical space, and they showed that actually if you're going to clean the skin before you actually go in to make an incision, it's actually better that you do it with chlorhexidine and alcohol than you do it with povidone iodine. And then people started to look at carriers of Staph aureus before you went to surgery. And there were a whole bunch of trials looking at, can we target? Can we find you? Those of you who have Staph aureus, which is about a third of the human population, find you, decolonize you, prevent you from actually getting Staph aureus related diseases. And so it's into that context that we decided to look at the potential for finding people, populations, not just moments, but actually populations that could benefit from decolonization much more broadly. So I'm going to talk a little bit about the ICU data, a little bit about the non-ICU data, moving outside of the hospital, and then ultimately into the nursing homes. So these were the beginning trials. There were 3 trials that came out in 2013, and these were large cluster randomized trials, and that means that we randomized, or they and we randomized groups, so units, ICUs rather than individual people, or hospitals. And the reason why you would do that is these types of interventions are quality improvement interventions. And so if you're going to study whether or not a quality improvement intervention works, it's really helpful to study it in the way that it would be used. So these trials are randomizing different hospitals or different units in the way that they would normally bathe, for example. So Mike Climo showed that in 9 academic adult ICUs, they could actually reduce bloodstream infections by about 28%. Aaron Millstone then did the same thing in pediatric ICUs, demonstrating that they could drop bloodstream infections by 36% just by changing out the soap, taking out the regular soap that was used and replacing it with chlorhexidine antiseptic soap. And then we took this to community hospitals. So we looked in 43 community hospitals in a system called HCA. This was 74 adult ICUs, 74,000 patients, and we're randomizing the hospital here. And so here we were randomizing the hospital to 3 groups. One who was going to swap out their soap and give everybody chlorhexidine, and they were also going to give everybody mupirocin. So everybody is getting decolonized because it's a human commensal for Staph aureus. Then there's a group that would screen everybody, and only if you were positive for MRSA would you get the antiseptic soap and the nasal ointment. And then the third group was routine care. So they're going to just screen and isolate just like all the other hospitals were doing. And during this time, what we found is that actually swapping it out completely, just changing the soap that you normally use for bathing was the most effective. It could reduce MRSA clinical cultures, and it could reduce bloodstream infections by this whopping 44%, which is a huge, huge number after we had worked so hard in the field to get that number already down by half by the time this trial actually happened. And the amount of adherence was very typical. You know, we didn't parachute research staff to do the work. And these were the actual people who normally have to bathe these patients that were doing the work. So the adherence is what you might typically expect when you're busy and you're doing a lot of other things in the ICU. So about 81% adherence for bathing and 86% for mupirocin. So then we were curious about whether or not we could take it somewhere else outside of the ICU, but you're still in the hospital, so you're still sick. You're not totally in your normal state of mind, and maybe this could be helpful for you. So we did a cluster randomized trial of 53 community hospitals, about 200 non-ICUs, 340,000 patients, because the risk is lower outside of the ICU. So it takes a much bigger effort. And what we did is we randomized them to 2 groups. One is do whatever you normally do with whatever you do at the frequency that you normally do it. So it's usually daily bathing with soap. Or you're going to switch it out. Again, same thing. You're going to swap out your soap. And now if you step into the shower, you're going to get 4% rinse off chlorhexidine. And if you're getting a bed bath, it's 2% leave on. And what we found is that decolonization was not very effective for everybody, but it was incredibly effective if you had a medical device. And so if you actually had a medical device, we could drop your risk of MRSA and VRE almost equally by about 35%. And we could reduce your chances of having a bloodstream infection by 32%. And this was pretty striking because in this set of community hospitals, only 10% of people had a medical device, but they were responsible for about half of all bloodstream infections. I think they were responsible for about 60% of all bloodstream infections. So a real high yield targeted group to go after when they're the ones that incur most of the risk. What's really interesting is the minute we knew the result of this trial, I picked up the phone to my C-suite and I said, we are using chlorhexidine in every patient in our hospital, and I'm about to just release these results, and I just wanted to make sure you heard it from me before it goes out. And yes, we're doing this. And you know, real credit to them. I said, look, these are community hospitals. We're an academic center. And they said the right thing. They said, well, okay, go back and show me of all of our patients, how many of them are in the ICU, what fraction of them are preoperative, so they're about to get a wound, how many of them are postoperative, how many of them have wounds in general, how many of them have a device, how many of them have a multi-drug resistant organism. And it was very clear that we should just keep doing the universal approach that we're doing, house-wide bathing, because targeting is harder. Like mentally, the effort that it takes to separate out as a healthcare provider, just these people and not these people should get this kind of soap and then switch out the soap for these other people is pretty complicated. So to this day across the UC system, so that's from UC Davis, San Francisco, all the way down to San Diego, we all are house-wide for this type of work. And I think that that's true for a lot of the higher level tertiary quaternary centers that have a very different population than a community hospital where the turnover is about every 3 to 4 days. We then wanted to take it out of the hospital. And we were really interested in this idea. There was a graphic, I should have put it in here. There's a graphic by the CDC that talks about MRSA. When you have MRSA on your body, when do you get into trouble? And so I just mentioned to you that the problem with contact precautions and the viewpoint, the vantage point of healthcare providers is they don't see them long enough. So if you're a primary care provider, you can see them get into trouble. If you're a nurse on the floor and they're gone in 3 days, you don't see what happens when someone acquires, for example, MRSA. So there's a graphic by CDC, and what it shows you is that when you have them leave the hospital, people who have MRSA, they get into a whole lot of trouble. And that trouble is pretty high in the first quarter after hospitalization. It's still quite high in the second quarter after hospitalization. And then it dives. But the truth is it does not return to baseline for a year. So their risk for these infections is higher than normal for quite some time. And so we were interested in taking a bunch of people who were not newly diagnosed, but they had a culture that admission. So it's not like they had a history of MRSA, but they had a positive culture that admission. And it didn't matter if it was a screening culture or an infecting culture, but just they know you had it right now. And we randomized them. This is an individual randomized trial. We sent them out either with education or with education plus serial decolonization. And for 5 days, twice a month, they were to shower with chlorhexidine, gargle with chlorhexidine, and do mupirocin in the nose. And we swabbed them. We did all sorts of visits where we swabbed them, and then we followed them out for a year to see if we could actually prevent disease. And so what we found is that we actually could drop MRSA infections by 30%, and the vast majority of those infections required hospitalization. And that's probably because you don't meet CDC criteria for having an infection unless it's well documented. So I think we were missing a lot of the outpatient infections, not that we weren't capturing the inpatient ones. But of these reductions, there were a lot of serious infections and a lot of bacteremias. And we could reduce all-cause infection by about 17%. And we could do this in a really nice dose response curve. So what was remarkable about these trials is the number of people who were perfectly content staying in your trial and being swabbed, but being content to tell you that they're doing none of it. So we have this really great data comparison of people who, if you don't do it and you're in the trial and you're in the decolonization arm, you do worse than control. And as you do more and more, you actually get more and more benefit. And it's probably because those people aren't taking their diabetic meds and aren't taking their hypertensives. I mean, who knows what else they're not doing, but remarkably willing to be swabbed and come and hang out with us periodically. So we then said, well, we know that MDROs are the highest in the nursing homes. We have swabbed so many nursing homes over the years, and it doesn't matter whether it's the work we've done in California or the work that other people are doing in Chicago, Wisconsin, Maryland. It is sky high, the amount of MDROs in nursing home residents. And so we thought, well, okay, let's help them bathe better and see if we can do something. And so we did this trial. This was just published in the past 6 months or so, 28 nursing homes in the Orange County, LA area, about 14,000 residents in the intervention period. And this is a cluster randomized trial. And we did the same thing. You can bathe with whatever you're using at the frequency that you normally do it, however you normally do it. And at that time, and actually true now, they're usually bathed maybe 2 or 3 times a week. They get some freshening up, and there's other things that you can call it, but basically full body showering or bathing about 2 or 3 times a week. And for the other half, we said, fine, do it the same way that you're doing it, but you're going to get 4% rinse off if you're in the shower, and you're going to get 2% leave on chlorhexidine if you're getting a bed bath. And because MRSA is so prevalent in long-term care, we're actually going to give you nasal povidone iodine, everybody all together, Monday through Friday, twice a day, every other week, just as one big fell swoop. We're going to protect the nursing home and hopefully also, of course, protect the residents. And so what we found, we knew by that time that chlorhexidine can reduce MDRO carriage. That's well known. And we swabbed them and we could prove that as well. But our target was higher. Like we wanted to stop readmissions due to infections. And so our main outcomes for this trial were, if you're hospitalized, can we reduce the likelihood that it's due to infection? And if you're discharged, can we reduce the likelihood that it's back to the hospital instead of to home? So we were looking at these kind of fractional reductions, and we saw these significant drops of about 17% reduction in the reasons for hospitalization or for discharge. And no surprise, the New England Journal said, that's all fine and good, but can you pick a top, can you give us a measure that's less obtuse? Can you give us a rate that the residents can say, what is it to me? You know, what is my risk of going to the hospital for an infection? And so those are the middle columns. It's actually higher, 31% reduction in infection-related hospitalizations for 1,000 days that you stay in a nursing home. And the number needed to treat is incredibly small. Now, these people stay a long time. So it's not a short intervention, but basically it's less than 10 people to prevent a hospitalization. And ultimately, when you calculate it out, you can save about 2 hospitalizations per month per 100-bed nursing home. It's huge, huge numbers to try to prevent a lot of the harm that we saw, certainly during COVID, but that we continue to see in nursing homes today. So these trials in healthcare have really shaped what we know, and you can just squint to see that they're high numbers, lots of people. And then on the right-hand side, the story is very, very consistent. It can reduce MDROs. And in fact, there are other studies, some that we've done, some that others have done really nicely that show it's not just the gram-positives, it's the ESBLs, it's lots of other pathogens that are in the gut, and even Candida auris. And we can actually reduce the infections that come with that colonization. So the bloodstream infections, the hospitalizations that are due to infection. So we were curious at trying to see, there's lots of things that we do in healthcare. And if you've seen kind of that Swiss cheese model, this idea that we do a lot of things because we don't want all the mistakes to line up. So what if someone doesn't wash their hands and then the person doesn't clean the environment and then you don't get bathed? And so like all the holes line up. And so then you end up with an adverse event. So some of the stuff that we do is to just try to prevent human nature from taking its course because everybody's compliance is say 80%, right? If you're lucky. But how much does it really matter? Like, are these things additive? Are they synergistic? Is it just toiling to try to prevent one thing from going wrong? And so we did this study. It's very small. It's a 2 nursing home study. But we took these nursing homes through 4 phases of intervention. Decolonization, control, we washed it all out. Cleaning, we did a much better job of cleaning, and then we put them together. And each phase took about 3 months to wash in or wash out. And then for the remaining 3 months, we serially sampled them every 2 weeks in a randomized way to try to understand what was going on. So this is the enhanced cleaning. And I think I told you that in hospitals, if you do nothing, the amount of removing of those invisible dots is about 40%. And you can get that up to 60, 70, 80 with a lot of effort. In the nursing home, what percentage of daily dots do you think are removed in cleaning? So after going into a bunch of nursing homes, we found that it's about 7%. And if you leave the dots for a week, you can get to about 22%. So they need a lot of help. And so we did a lot of intervention to kind of clean this stuff up. And then we would go in and we would literally go in the day before to the nursing home. We'd figure out who was in a bed. We would randomize the beds and then go in and sample about 50 people. And so we got about 2,000 body sites for that. We did the same thing for the rooms. We would randomly select resident rooms and then go into the common area and then swab high-touch objects. And so, again, this is only 2 nursing homes. It's really, there's no confidence limits on these. It's pretty broad. But you can see, if you just look at the point estimate of who has an MDRO, you can see in the control arm, and we did not do perirectal swabs here. We just did skin and nose. When you add in the perirectal, you get to the 65% number that I was quoting. So 50% of controls are positive for an MDRO. During the decolonization phase, you can bring it down to 36%. And then if you take a look at enhanced cleaning or the two together, they don't seem to add much. Now, remember, this is body sites. When you're cleaning the environment, you're not cleaning the body. So we didn't really think that the environment was going to do anything to anybody's carriage, right, of an MDRO. And so when you actually do the actual analysis for odds ratio, you can see, again, decolonization has a big impact. Enhanced cleaning doesn't do much at all. And the two together is really no different than decol alone. So then we looked at objects, right? So now we're actually doing the cleaning. We're getting the cleaning, those dots to be removed. And you can see that in the control phase, the cultures, MDRO cultures of objects is about 60, 70%. You drop it quite a bit with decolonization alone. So remember, they're not kind of this big plume into the environment. You're stopping the shed, and you can see it cuts it by about half. And then cleaning itself does a pretty good job, actually not quite as good as decolonization. And putting the two together seems to have it's certainly not additive. And so you can see here when you do the actual analysis that clusters on the nursing home and accounts for the objects that are being swabbed and the rooms that they're in, you can see that actually decolonization actually works better than cleaning to actually keep the pathogen contamination and high-touch surfaces down. And that's not to say that we should do only the decolonization, but it talks a lot about behavioral. How long does it take to handle behavior? And it's really hard. When we're talking about each of these things, cleaning your hands, cleaning the environment, it all takes an enormous amount of effort. So how do we think about how we parse that effort in a way of making sure that the most effective things don't fall to the wayside? So currently, about 63% of ICUs in the last CDC survey nationally, in 2021, 63% are using universal decolonization in the ICUs. About half of those, little less than half of those, are doing nasal decolonization. And there have been a number of kind of federal funded projects to try to get that number up to speed, faster than the 17 years it usually takes to adopt things in healthcare. So I'm just going to take the last few minutes and talk to you about the last thing, which is antibiotic stewardship, another really, really difficult subject for overprescribing. We prescribe way too many things. These antibiotics, they kill the susceptible things. They allow the resistant ones to remain. And clinicians here in the United States, we prescribe absolutely an enormous amount of unnecessary antibiotics, and we tend to overestimate the risk. That is, we prescribe to our worst memory, we prescribe to our worst nightmare. And the combinations of those two things doesn't bode well for the amount of antibiotics that are out there. And so the solutions looking into the future now that we have an electronic health record is to think about what can we automate? How can we get information to the physicians at the time that they're making a decision? You're typing in the order for vancomycin for MRSA. And at that moment, can we deliver something to you that is personalized about this patient that you're prescribing it on and is actually documented so that we can actually prevent people from saying that you have to be prescient. You have to know what's going to happen in order to be correct in medicine. And so these trials were just published, I think about a week ago. These are the INSPIRE pneumonia and UTI trials. And it's this idea of trying to put smart prompts out to guide antibiotic use. So these are two separate trials. And we looked at about 60 community hospitals in the HCA healthcare system. And this is what we did. One side just got whatever they're normally doing, routine care. The other side got these smart prompts. And depending on what the doctor typed in, if they typed in an antibiotic that was what we consider broad spectrum, which means it's supposed to go after drug-resistant organisms, then it would rapidly calculate the risk that that patient, based on the information that's in the EHR that we know about that patient, is their risk over or under 10%. And if it's 10% or greater, you can have it, which is a really low bar in the United States. But in the United States, we give a lot more than that. So 10%. Under 10%, you get a prompt. And it says this person's actual risk is less than 10%. And here's a one-button exchange for you not to do what you're doing. So it's pretty specific. So we had to run a bunch of models because there's a lot of antibiotics that doctors can prescribe. Some are targeting one organism, some are targeting multiple MDROs. All of them would toil on the 10% risk that anything that they were targeting would actually come back and be risky. And so there's a one-button response. This is what it looks like. It says cefepime is not recommended for empiric therapy because this patient's risk of pseudomonal pneumonia is less than 10%. And then it would store it. So the very first time a physician has what we would call cover, for the first time, it's in the chart what that person's risk is at the time I had to make a decision. Right? So I'm not going to be held responsible that if this person had a 1% risk of growing Pseudomonas and it grows, I'm not at fault. Because at the time I was using all the available data that was in my power to know whether or not this person needed to have the broader spectrum antibiotic. This is the use in HCA hospitals. You can see that 40% of people get an extended spectrum antibiotic. And this is how many grow a multi-drug resistant organism out of those that are cultured. And you can see that it's vanishingly small. So we use an exorbitant amount of antibiotics, and this is in the non-ICU. So there's good data that suggests that you can wait for the culture to return. And this is the final result of these trials, that basically we could see a very large reduction in extended spectrum therapy, both vancomycin, anti-pseudomonals, and no difference in harm, no difference in length of stay, no difference in transfer to the ICU. But it does leave a question. While 28% is whopping and got us this really, really nice paper, what is holding back 70% of doctors or the 80% of doctors who don't want to listen to a prompt, right? So there's a lot more about behavior that needs to get done. But the good news is that I think things are going to change. We're on the cusp of a very robust EHR system. You can do lots of smart things for precision medicine to really tailor things that are specific to the person and their risk factors. But we do need to be attentive to physician behavior and what makes them prescribe and how do we make them feel comfortable. So this is my last slide, just to say that there is a urgent and perhaps a growing need all the time to address multi-drug resistant organisms. There's lots of things that we can do, and all of these strategies are behavioral, and they require a lot of corralling. And so how do we actually use data from trials and electronic systems to actually help the buy-in by staff to make it easier to use at the front line? And that vantage point, which isn't just what can we do for our patient, but increasingly with burnout, staff opinions and provider opinions really, really matter and have to be taken into consideration. So thanks very much, and I'm happy to talk to you.
All right, are there any questions from the room? Otherwise, we have a lot online, so we can start. Yeah, the first question online is 70 to 80% of antibiotics in the US go to agriculture. Are there many studies on hospital versus farm-associated MDROs, e.g. links between nosocomial AMR infections and concentrated animal feeding operations?
Yeah, so there have been a lot of folks that have looked at this across different countries. We were pretty fortunate that a long time ago, there were rules for regulatory reasons here in the United States that you can't use antibiotics that are used for human disease treatment widely in agriculture. It's pretty good. We've done quite a good job, and for that reason, it took a lot more time for some of the VRE and other types of pathogens to be found in our food supply. It's not perfect, and I think you can tell that there's a lot of pushing and pulling in agriculture. You know, it's interesting to me that when we talk about infection prevention in hospitals, we talk about infection prevention. When you talk about agriculture, they call it biosecurity. And what they're referring to is not decimating a flock or decimating the food source for humans, which often is obviously economic. So I think overall, I'm sure it's a major problem. We don't measure it well enough to know how big it is. And at least in the proximal sense, they're not using things that we use for therapy. But the cross effects for resistance are not well understood.
Thank you for your talk. You did all these comparisons between the decolonization alone in nursing homes and then the decolonization and cleaning. And I was just really surprised to see that the combination approach seemed to be like pretty stubbornly higher than the decolonization alone. Do you have ideas about that? Even if it's not additive, I'd expect it to at least be a little
Yeah. So the tail end of that study, the pandemic hit. And so we actually took a big break in that study to try to just calm the system down. We didn't want to measure when nobody was willing to do anything. So there's a lot of turnover, so we're not really sure. And when we did the black light markers, though, I'll tell you that by the time we measured it, it was actually higher. So the removal of the black light was better, but the point estimate for actual removal of the pathogen wasn't great. So small numbers, but what it at least showed us is it's not synergistic in the way that we would hope. And we have a long way to go in long-term care.
Picking up on that theme, is you need to clean the whole room. So there's a suggestion for penicillin-resistant antibiotics, others that it's the sinks or other areas that seem like the reservoir for spread, at least in ICUs. Is there a sense in which there could be targeted cleaning of rooms in order to be most effective in reducing spread? Or does it need to be full room flow?
Yeah, so I think I don't think we'll ever get to a tailored strategy where we actually only clean certain things for certain people. So it'll still have to be a policy that works well for the room. I think that what patients see matters. And for that reason, you will dust and you will set the room in order so that visually the whole room looks like it's cleaned. Whether or not you actually remove in a disinfectant way, I think it's going to be highly variable. But we get into trouble. What is consistent is we get into trouble with the things that are most commonly on us. And so whether or not you're targeting a resistant organism or a sensitive organism that's going to cause a skin infection probably doesn't matter. Either way, I'm guessing that the room needs to be cleaned. Whether or not it needs to be vaporized, with like hydrogen peroxide vapor or the other things, the UV light things that are out there, I think it's not so clear. I think in general, people touch a handful of things in the room, and those things need to be monitored and fed back. And I think people are doing a pretty poor job of the other things anyways. They know people aren't touching ceiling, floor.
In the trial with the infection prompt for providers, were patients given that information? And do you think that would either increase or decrease the success of the solution?
Oh, I think it's such a good question because in all of the things that we're talking about, the patient vantage point is not always tethered to what the provider thinks. Certainly when we stopped caring about MRSA, the patients did not. I'll just give one anecdote before I answer your question. But we did that trial where we sent them home with product, and some of them had some allergic reactions, mild. They wouldn't stop. Like if you actually look at the one sentence on that adverse event, most of the time you think, oh, you got, your skin itches, just stop. But about a third of them wouldn't. They cared more that they had the MRSA, then they would just treat through until it went away. And sometimes it wasn't due to the product and they were fine. So I think that you're right. This type of prompt that is very antibiotic specific, the patient would have no idea what to do with it. And the patients are very trusting of their physicians. So they'll say, well, whatever my doctor, it's very natural that they're not going to step in and make that type of high level decision. But I do think they can make decisions about bathing and other types of cleaning, especially at home.
There's another question online. There has been some controversy on whether organisms develop accident resistance from frequent use in clinics. What is your experience with this?
Yeah, so there the data that have been, I'll tell you that we haven't found it. So we have surveyed thousands and thousands of isolates from our trials. And we cannot demonstrate a lot of chlorhexidine hardly at all. We can't find it. The genomic markers for it are horrible. The ones that are out there for block gene, and they don't correlate at all with the phenotypic, the demonstration of phenotypic resistance. And we don't see that it's burgeoning differentially in the arm that got the decolonization. So there's secular trends for things, but we can't find it. And so it will come. I don't think any of us are deluded enough to think that we can give chlorhexidine forever, especially as we're loading it higher and higher into healthcare. But I do think that what we need to do is create other antiseptics that can be studied in the same way. And the pathway for that through FDA is not yet clear. So there's a lot of work to be done to figure that out. But luckily for us right now, it does not appear to be a problem. And we actually have, these studies were done in the same health system. The very, very first trial that I talked about, the reduced MRSA trial. And then the later study when we were looking at another comparison on whether the nose matters, whether you got mupirocin or povidone iodine in the nose. And it does turn out that the nose matters, but we were able to look at the hazard as long as you stay in an ICU. What's your hazard of getting a Staph aureus, an MRSA infection, for example? And we could overlay, because this was a health system that had been using this product now for 10 years. And everybody in the ICU was getting mupirocin. Everybody in the ICU was getting chlorhexidine bathing. And we could overlay the two graphics to see whether or not it had changed. And they look almost exactly superimposed. So the fact that for over a 10-year period, we could continue to do great good, and maybe it's because of the high turnover in ICUs, these aren't the same people, most of them over time. But so far, we're in this window of time where we have the time to find another antiseptic, demonstrate its utility, and continue to use chlorhexidine in the way that we're doing.
I know there's been some work on decolonization for healthcare workers, but what are your thoughts on decolonization of visitors, in particular to nursing homes?
So lots of people were looking at this for a while in the United States a couple of decades ago, and then in Europe again. It kind of comes up every couple of decades where they start to really see, is it the healthcare worker, is it the patient? And overwhelmingly what we find is actually that the healthcare workers are vectors. And so rarely will we use it. First of all, they're very sensitive if you tell them that they need to be decolonized. There's a lot of legal issues that it will take to screen your healthcare workers, much less to intervene on them. And the tendency is to do it under an outbreak setting. When it's very clear that harm is happening in their unit, then they're very willing as healthcare providers to do a lot. Outside of that setting, it doesn't appear to be necessary or the most top 100 things that you should go after. So I think fortunately, and visitors even less, so they're not going room to room. The transmission characteristics for them is pretty low, right? Within a family, yes, but not across. So if we can clean the room after they leave, maybe we'll do fine. If we can clean the common areas, maybe we'll do fine. So not a lot of effort or interest in studying that space.
All right, I think we're at the end of the time. Thank you so much.
Thank you.